Hi, I'm Nina Collins from Revel. I'm very excited to meet you, Sharon. I've heard a lot about you. Can I call you Sharon or should I call you Dr.
Yes,
Malone?
absolutely. No, call me Sharon.
Okay. I actually have to tell you at the end that I had dinner. Well, anyway, I had dinner with someone who knows you well recently, and she was raving about you. Maybe I'll tell you afterwards, but it was great. So I'm very glad to meet you. And I love Anne and Monica. We love our partnership with Alloy. So we're here today to talk about menopausal hormone treatment. I'm going to introduce Dr. Sharon Malone first. Sharon is among the nation's leading OBGYNs with a focus on the specific health challenges associated with menopause. She's also the chief medical officer at Alloy. Born in Mobile, Alabama, the youngest of 8 children, Dr. Malone was raised by her siblings after the death of her mother and moved multiple times, changing schools 4 times in 4 years in 3 different states. Dr. Malone found strength and resilience in community, in her own work ethic, and in her strong belief that there are no accidents in the universe. She went on to graduate cum laude from Harvard with a degree in psychology and social relations, and later graduated with honors from the Columbia University College of Physicians and Surgeons. Upon completing her residency at the George Washington University, Dr. Malone served women across Washington, D.C. in almost 30 years as a practicing OBGYN in her practice there. As Chief Medical Officer of Alloy, Dr. Malone wants to bring her expertise to women on a larger scale. She believes that all women should be able to make decisions regarding their health and quality of life based on facts, not fear. That's a great bio. You also wrote a kind of fabulous piece, I thought, on abortion rights, and which we published on Revel. So you guys can find it if you search on our blog, search Dr. Malone, and it will come up. So thank you for that. I thought it was really well done. So we're here to talk about menopausal hormone treatment. My first question is, why are people changing the name from HRT? And what should we really be calling it? And how do we get clarity on that?
You know what? I think that you can call it whatever you like to call it. But, I think that the notion of hormone replacement, there was some conversation about whether or not we were actually replacing hormones or supplementing hormones. So I think that menopausal hormone treatment, MHT, is the new moniker that we're using for it. But it also, you will see it referred to as estrogen therapy or ET, or EPT, which is estrogen progesterone therapy. But for all intents and purposes, they're all the same thing. So,
I don't. Same thing, but delivered in so many different ways that I sometimes find it super confusing, right? So I'm on what I think of as HRT, MHT, EPT. I'm on an estradiol patch of 0.075, and I take 100 milligrams of progesterone a day. And it has been kind of life-changing for me. And my mother also died when I was young, Sharon. My mom died when I was 19 of breast cancer. So I resisted going on hormones for a long time. I'm 53. How old are you?
I am 63.
Nice. Okay, my boyfriend's 63. I'm going to be 53 on Monday.
Happy birthday.
Thank you. So were you ever on HRT? Is it okay to ask you personal questions?
Oh, of course. Yes. I have been on HRT from the moment I was menopausal, probably even before, and I'm still on HRT now.
Wow. Oh, then this is great to talk to you about this. I'm very curious. So for most of our listeners, you probably know there was a famous study that was done that basically told all of us that hormone replacement therapy was dangerous and bad for us and would cause us breast cancer. And that has been largely debunked, although, and Dr. Malone can really tell us, but my understanding now is that not only is it safe, at least until we're around 10 years into menopause, or to around 60 for sure, it may be helpful. It may actually be good for our brain health and our cardiac health. But my understanding is that after age 60 or so, it's still kind of up in the air. So I'm very interested to know that you're 63 and still taking it.
Yes, I think that here is something that I think is really important to know is that Women's Health Initiative study that was reported out now almost 20 years ago this month, said a lot of things that scared women away from hormone replacement therapy. And I think that at that point, the number of women who were on hormone replacement after menopause was about 40% of women took hormones of some variety. After that study came out, it plummeted to less than 7% of women were taking hormones. And the women who were on it basically because they were symptomatic, they felt better, they needed the benefits of hormone replacement for symptom relief. And we only got into trouble when we started using or reporting that hormones was preventative for certain things. And that was what the Women's Health Initiative sort of came out and said, that it did not prevent cardiovascular disease, which was what the study was supposed to actually prove. But here's the problem. Yeah, that was really the purpose of the study.
I didn't know that.
No, there was no question about whether or not hormone replacement was effective in treating symptoms. I mean, by the time this study was started, we had 40 years of experience that says, yes, it works for hot flashes and mood swings and all the other things that women would take hormones for. But when we got into that prevention mode and we were trying to prove that it prevents or decreases the risk of heart disease, was where things started to unravel. And the basic problem was with the design of the study. If you're going to do a prevention study, you can't enroll women in the study who are anywhere from 50 to 79. And that's who was allowed to participate in the Women's Health Initiative. So it makes sense that if you have someone in the study who is 75 years old, whatever heart disease that she has or risks, they're already there. And no matter what you do at that point is not going to prevent, future heart disease. And that was why they could not prove the link of cardiovascular disease. We've always known with hormones that there was a slightly, and I say that ever so slightly, higher risk of breast cancer. But when you couple those findings, it does not decrease the risk of heart disease, and there's an increased risk of breast cancer. Well, you can imagine that was like, a match to a gasoline fire.
Right.
Women just said, oh my God, when you say the words breast cancer, women will run away from it in droves. And I think that has really been a huge disservice, because as we've looked back on the Women's Health Initiative, we found that not only is the cardiovascular issue probably it is beneficial, but it depends on when you start hormones. You can't start at 75 and expect to
start younger.
But you start at 50. You start between the ages, or the age of the natural menopause. And I think that something that women should really understand is that the younger you are when you have menopause, and there will be women who are menopausal in their 40s, the more benefit there is to hormone replacement, because it does not leave you susceptible to those long-term issues with estrogen deficiency, like
osteoporosis,
Alzheimer's, sexual dysfunction, urinary issues. So there's a lot that goes into that. And I think that the reason why it's been so difficult to unwind and to really correct this story is that, bad news travels fast, and it's sticky. And, and it has become so much a part of the conversation, I think, amongst women and even amongst doctors. Many doctors do not, even understand what's going on. So unless you take a particular interest in menopause and menopausal women, the amount of time that it takes to explain a study takes too long. So it's just easier to take.
Doctors don't have time. They have to, right. So let's be clear. What is the current stance on breast cancer and menopausal hormone treatment?
Okay. The current stance is that if you take hormones around the time of the natural menopause, anywhere from your 40s to your 50s, at least until the age 60, there is really no significant increase in the risk of breast cancer, even for women who take estrogen and a natural or micronized progesterone. That's the state of what the data has shown us up to this point. And that is contrary to what was shown in the
contrary to what was shown. And interestingly, I went to get my mammogram the other day, and there was a checkbox: are you on hormones? Are you on HRT? And I checked yes, but of course it made me feel bad about myself. It made me feel like, oh, are they asking because now they're going to extra look for cancer? It feels like there's not enough clarity around all this, and it does feel kind of sexist also, that we feel like women just don't really know what to do.
Right. And I think that, even if you, and we can talk a little bit more in detail about the long-term benefits of hormone replacement, but the short term, I mean, quality of life is important for women.
It's huge. I went on it because I finally was having so many hot flashes that I couldn't function. And I was like, this is not, and I wasn't sleeping, and that doesn't seem healthy.
Right. Just having interrupted sleep, and not only for, weeks, but months, years on end, that independently is a risk factor for cardiovascular disease. So the more symptomatic you are, and if you are, again, and you have hot flashes, night sweats, irritability, all of that stuff, it all plays in together,
It affects your life. Yeah.
Right. And to tell someone, it's one thing to say, don't worry, you'll get through it in 2 weeks, but it may be a decade or more before these symptoms go away. And that is just no way to live a productive life for women. And here's something that I think is really important that I want women to understand. I am here as an advocate for women, for agency, for being able to have facts in front of you and to be able to make decisions that are right for you, not only in terms of quality of life, but also your long-term health benefits. And, and I don't like to get into these arguments where, you got hormone camp and no hormone camp, and we're duking it out.
Right.
I want women to have the information that they need to decide, and don't base that decision on information that we had from 20 years ago, which was erroneous and was misinterpreted. I mean, because I think that's where we are, unfortunately, 20 years later, but we're making progress.
We are making a lot of progress. There are companies like Alloy and companies like Revel where we're talking about this. I mean, women are really talking about menopause now in a way that I don't think we were 20 years ago, in a really frank way, and it's hugely important. Can you talk to us about bioidentical hormones? Because when we think about hormones of yesteryear, we think about horse urine, right, and Premarin, and so what are bioidentical hormones? What does Alloy use? What's your recommendation for what to use?
Yes, bioidentical hormones simply mean that the compounds that are in your estrogen and in your progesterone are identical to the hormones that your ovaries would produce naturally in the course of a natural cycle. So the estrogen that's in a bioidentical estrogen, it is 17-beta estradiol, which is the native compound that your ovaries would make. The same is true of the progesterone. We use micronized progesterone, which is the same progesterone or the progestin that the ovaries produce. Now but the terms bioidentical have nothing to do with how they're produced. You can have bioidentical hormones that are manufactured, that are FDA approved, that don't come from, that someone hasn't dug up out of the backyard, that whole sense of what's natural. Those are more marketing terms. As opposed to,
so are we all taking bioidentical hormones, or are there hormones we should not be taking? I guess.
Well, even with that, let's take best case scenario, worst case scenario. And best case scenario is that if you're taking bioidentical FDA approved hormones, you can take an estradiol, you can take a micronized progesterone that is what your body looks to your body like what you would have produced had you produced.
Okay.
That's best case scenario. So what is the data on bioidentical hormones? What we found is for women who take, and let's get back to the breast cancer issue because that comes up again and again. For women who take micronized progesterone, which is the bioidentical, it appears that even the changes that you see in breast density, that you might see on some of the other progestins, you do not see. Even the slight, and I want to emphasize this, the slight increase in risk of breast cancer that they saw in the Women's Health Initiative was with a synthetic progestin, which was not bioidentical.
Interesting.
That it's even that slight increase does not appear to be the case when you use the micronized progesterones. All right, that's best case scenario. But let's go back to even say, what's the worst case scenario? Because the Women's Health Initiative was done with a synthetic progestin, medroxyprogesterone, which is not bioidentical. It was the only progestin used in that study. And that was the only instance where they saw a slight increase in the risk of breast cancer. And that was the harm for which, one of the harms for which the study was stopped. But let's even take that worst case scenario. The worst case scenario, even that increased risk was of borderline significance. It wasn't even, it wasn't, it was like, oh my God, it sounded horrible to say that.
I mean, honestly, it's enraging to think that all these women were told they had to go off hormones, and we were terrified for years and years.
Right.
Yeah.
And even, like I said, even if you took the worst case out of the Women's Health Initiative, even that, if that increase in the risk of breast cancer had been exactly what it was, but you had seen the benefit in the cardiovascular front,
right.
You know what you would have said?
And Alzheimer's.
Yeah,
Right.
you would have said
Right.
because
No problem.
the benefits would have outweighed the risk. And even that risk for the worst case scenario is actually still quite small. And that's what I want women to get to understand, is that, yeah, there may be better alternatives, but even the worst alternative is still not that bad.
Yeah, no, this is great. I mean, I have this conversation a lot, and it's every time I learn more, because I'm not a scientist. It's really helpful. I really appreciate it for everyone. I'm going to go to a couple questions in the audience, but I want to ask you one more question, which is that, do you think in the coming years we're going to see women older, in their 60s and 70s, staying on the patch more commonly?
Yes. And, and here is also, there is some good news in terms of the evolution of our thought process on hormones. And the North American Menopause Society has recently, just a couple of weeks ago, released new guidelines, consensus guidelines on the use of hormones. And this was updated from about 5 years ago. And here's the good news about this. They have taken away some of these, this sort of nebulous language, like, women should take the least amount of hormones for the shortest amount of time. Okay,
right.
What is
What
that?
does that mean?
What
Right, exactly.
Do you have to stop at 60? And what the new language says from the North American Menopause Society is that women can decide. And if you get to 60 and you still are symptomatic and you have none of the other contraindications for taking hormones, there is no reason that you must stop. The same is true. So the decision is really, this is where we're bringing patients into this conversation.
Yeah.
Because as long as you want to continue, you're doing well, and you personally have not had breast cancer or a blood clot or undiagnosed bleeding, then you may continue.
And I mean, I'm sure you hear this, but I've met women in our community who have told me their doctor will not let them stay on it, and like literally will not let them, and they have to go find a different doctor.
And that to me is the crazy part of this. Your doctor won't let you.
Yeah, what does that mean?
We're grown women,
exactly.
And we are all capable of weighing risks and benefits, because let's just say there is no medication out there that does not have a risk benefit profile. I mean, aspirin, Tylenol, cholesterol medication, it all does. And the notion that women have to be told yes or no, or doctors won't allow you to take that, is really, a little patronizing, I would say.
Yeah, it's patronizing for sure.
I'm 63 years old. I feel great. I don't have any reasons not to take hormones. I would not feel as great if I didn't take them. So my decision is I will continue, and I will continue unless or until I have a reason not to take them. And here is a big, a point that I want women to understand too. The overwhelming majority of women who develop breast cancer are, the biggest risk factor you have is living long enough to get breast cancer. And that's regardless whether you take hormones or you don't take hormones. So no one can tell you that while you're taking hormones that you won't get breast cancer. You might, if you live long enough, but you might get breast cancer. But here is the point that I think is missed in this conversation, is that even women who get breast cancer while they are on hormones, even though you would have to stop your hormones because you have breast cancer, your prognosis is no worse than if you hadn't taken hormones. And if I you took the micronized progesterone, you have an increase your risk over baseline just for age after you get to a certain point. And so if it's no difference in terms of outcome, and you've derived all the benefits from osteoporosis prevention, from the urinary tract issues, from all the symptomatic relief, you're in no worse position than you would have been had you not taken hormones. And
I mean,
that's
the bottom line is we're all getting older and stuff's going to happen. I mean, that's just the reality, you know.
But you can't take hormones for 20 years and, you know, and now you're 70 years old and then say, oh, I shouldn't have taken those hormones because you get breast cancer at 70. The likelihood is that you got breast cancer because you're 70, not because you took 20 years of hormone replacement.
Right. Super helpful. Super helpful. All right, let's take a couple questions from the audience. Someone says, I'm in my 40s and have been experiencing perimenopause since my early 30s. I was told that it's common for women who've never been pregnant to experience early perimenopause and menopause. Is this true? I've never been pregnant.
No, not really. I mean, it's not, I don't think it has anything to do with pregnancy, but there is sort of a genetic component to it because each of us, you know, when we are born, our eggs are stamped with a certain expiration date, and we don't know what that is. And there's women who are going to be perimenopausal and menopausal in their 30s and 40s. Fortunately, that's not the majority of women. And there's some women who are still having their periods.
I have friends in their late 50s who are still getting their periods.
And they're sitting there going, what the hell? They're looking for menopause, you know?
Exactly. Where's menopause?
Why?
But sometimes I think it's so strange to remember that we used to bleed. Like I haven't had a period in like 5 years now, and it seems really alien.
Yeah. No, so no, it's not that, but it is more sort of, you know, we don't know what our genetic, you know, expiration date is. Yeah.
Right. All right. Next question is, hello, Dr. Malone. I'm on HRT patch 0.1%, gradually increased in the past 2+ months, and 100 milligrams of progesterone. It's been very helpful to alleviate most symptoms. It's been about 5 weeks on this higher dose, however, and I'm still experiencing brain fog and panic anxiety when I wake up with a minor hot flash, although it's not as extreme as it was. Are there other options since I've maxed the patch dose? Perhaps oral estrogen?
Yeah.
Would it absorb differently than the patch? I didn't know that the max of the estradiol patch is 0.1%.
Yeah, they just don't make them any higher. You've got a lot more dosing flexibility with oral estrogens, you know, that you can go up as high as, you know, to give you an idea, a starting dose of an oral tablet would be a 0.5 milligram. You can go to 1, you can go to 2. And for younger women, the younger you are when you go through menopause, the more likely you are to need a higher dose of the estrogen. So that is, you know, that is just a function of the fact that they just don't make them. There's no science behind why you can't have more than 0.1. It's just that they patches don't come in that dose.
So there's no like recommended, I mean, you wouldn't want to overdose on estrogen.
Right. But you know what we use, a common, I think the easiest way to know when you're on the right dose, because again, it's going to vary from person to person, how old you are, whether or not you're coming off birth control pills, because birth control pills have much more estrogen in them than menopausal hormone therapy does. So sometimes you might need a higher dose to control your symptoms for a while. But, you know, all of the studies that were done were just sort of standard doses. So no one knows what the, you know, what's the top, what's the bottom on these, but we use as a marker for when you're on the right dose is when your symptoms go away, you know?
Okay. So it sounds like for this woman, she should talk to her doctor about perhaps adding oral estrogen.
Of course, switching the modality, one or the other, don't do both. But what I would say to you is this, is that the hot flashes are the easiest thing because they go away the quickest, you know? So if you have a patch or a pill or whatever way you're taking estrogen, you'll know you're better within days, because your hot flashes will go away and you'll sleep. Some of the other things like the irritability, the panic, the other thing. And here's another thing that came out of the North American menopause regulations. Sometimes they found that for women that have more mood components, that adding a low dose, and not at the level that you're treating depression, but adding one of the SSRIs like paroxetine or any of those, the effect of the estrogen plus the low dose antidepressant works better than either of them alone.
Either of them alone. I do both. I'm on Prozac with my HRT, and it really has been just a very winning combination. I feel fabulous.
Right. So it may be that the answer, particularly when it's not the hot flash that we're using, then adding another low dose SSRI to control some of the panic anxiety components of it might be the better way to go.
And what this points to also is that it's just very different from woman to woman. And you really need a doctor you can talk to kind of work it through, because it often takes a lot of trial and error. But once you hit on the right combination, you're good. It can be great.
That's exactly right. And that's why I said we don't have to spend a lot of time, trying to convince women to do this or not. You will know,
you know when you need help. But you need to ask for it and not be embarrassed and know that there are answers. I think that's one of the things I feel most strongly about is I want to make sure women know that there are answers. You don't have to be ashamed and feel in the dark about your vaginal dryness or whatever. We're all in the same boat.
Exactly.
All right, 2 more questions. I know you're a very busy doctor and I love talking to you. Is it too late to start hormone therapy in your 60s?
Again, this is something that I will take. This is where this is the art and not the science of it, because there's not a lot of science about it. So just bear that in mind. And I always like to tell you when I can back something up by what I know and what I think. So bear this in mind. There are 60 is we use 60 as the end point of when, the age beyond which you should not start hormone therapy for the first time. And that's simply because, as you get older, again, breast cancer risk goes up just from as we said, from aging, blood clots, other things that may be other cardiovascular risk factors that may have already sort of codified and they're already there. But that's assuming that you were menopausal at 50. So
I see. I see. So if you don't start menopause till 56,
right? If you don't start there,
then start your hormones. Oh, duh! That's like a basic math problem, and that never occurred to me. Not every woman starts menopause at the same time.
Exactly. So it's 60 or less than 10 years.
10 years from your last period, basically.
Right.
Okay.
So that's not a hard and fast rule. So that's number one. And the other issue is that requires just a little bit more conversation, because there is also this notion about starting for women. And there are women who are still miserable in their 60s. And there are ways to start hormones that would cause less, fewer side effects at lower doses that women can start at that point as well. And here is where I think that there is also a good time to mention that a study after study after study has shown that just estrogen itself, just estrogen alone, does not increase your risk of breast cancer. And that, I think, was lost even from the Women's Health Initiative. For women who had had hysterectomies, and did not have a uterus and who had been on estrogen alone, not only was there not an increased risk of breast cancer, but the risk of breast cancer was lower than women who didn't take hormones. So for anybody who's out there who's had a hysterectomy, again, you've got a lot more leeway about when to start hormones. And also, as you get older, it might be better to use like a transdermal, which would be a patch, as opposed to a pill, because again, that would be safer just as far as the side effect profile.
So really, really good to know. It's important to take this. So it's not hard and fast rule. A lot of it depends on when you went into menopause and whether you have a uterus and all the rest. So yeah. Okay. All right. So my last question for you is a little off topic, but it's hormonal, because I hear such conflicting information about testosterone. I'm curious what your opinion is on testosterone. Some women put these pellets in their butt to increase sexual response. Some women I know do testosterone cream on their thighs. My gynecologist is very anti-testosterone. I've asked for it because my orgasms are not as good as they once were. What's your feeling about it?
Well, you know what? Testosterone actually, things that we don't think about, when you ovulate every month, when you're not on pills and you're just a young person, you make estrogen, you make testosterone, you make progesterone. So all 3 hormones you make. And the testosterone does have a role in sexual desire and in sexual function and performance. So adding testosterone back is not a bad idea. And there's a fair amount of evidence that says for women that have libido and sexual dysfunction issues that it can be helpful. Here's the caveat. There is no FDA approved testosterone preparation for women in this country. There is an FDA, they're not FDA, whatever their equivalent is.
Yeah, whatever their equivalent is.
That they do have testosterone. And since we don't have it, these are your only options for how to access it. One, you can use compounded, and remember, compounded is different from bioidentical. But here's the problem with compounded hormones. Because they are not FDA approved or inspected,
you don't really know what you're getting.
You don't know how much is in it. You don't know anything about the purity of the product or the efficacy of it, because someone is back making something in a batch with a mortar and pestle. And
yeah, that sounds a little scary. Yeah.
So generally speaking, I think that all of the governing agencies sort of say compounded hormones, unless under rare circumstances, you should avoid, simply because they are not regulated.
Got it.
And two, testosterone, if you take a little bit too much estrogen or, a dose up or down, is there going to be any harm or foul? Probably not. Testosterone, by contrast, has other side effects, that some of which are irreversible, such as deepening of the voice. You can have an enlargement of your clitoris. Women will get acne. You'll have hair loss if the dose of testosterone is too high. So if you are going to be on a testosterone, then what I would say is that your blood levels of testosterone need to be monitored, which they do not need to be monitored if you're on estrogen, because you have to make sure that you are not outside the physiologic range for women. And
basically,
so that's
so very good answer. That's really helpful. For me, that means it's like a bridge too far. It seems too complicated. I don't want to go down that road, but it is frustrating that it's not studied and that we don't have an FDA approved product, and that, because again, women's sexuality, I don't think is taken seriously enough.
Exactly. And therein lies the problem, because the only FDA approved testosterone medications in this country are formulated for men, patches and gels. And so what some gynecologists do is they use off-label, they will use the FDA approved testosterone, but titrate it down, because women need about a tenth of the dose of what is recommended for men. But you can imagine how easy that is to mess that up, because
of course, it's an interesting subject to me, because in my job, I interview a lot of gynecologists. And so I've met quite a few who just swear by it, love it, and then my own gynecologist thinks it's like crazy and bad. And so I'm always kind of curious to get more information on it.
I think it is helpful. And I think it's unfortunate that we don't have that pre-dosed, FDA approved for women who need it. And because some women really do find it helpful, but we're not quite there yet. Stay away from pellets though, because pellets, the problem with the pellet, and I will tell you this, is that, again, you have all that problem is that it's been compounded, so you don't know exactly what's in it. But once you give a pellet, the pellet lasts for 6 months. You can't take it out.
You can't take it out. Whatever you put in your body. No, and a woman I spoke to last week, really had more hair growth. I mean, it just seems for me, it feels just too experimental. I don't want to play with hormones like that.
But I say all that to say, not no, not never. But I think that we need better preparations of testosterone.
More information. More studies and better preparations. Well, it's been such a treat to finally meet you. We've been working with Monica and Anne for, I think, almost 6 months now. And I'm just really glad to have finally met you. For our listeners, this episode is sponsored by Alloy. Sharon Malone is the expert for Alloy. Alloy is sorry, I'm blanking on the word, a telehealth company for menopause. They prescribe hormones. all sorts of products. We really love them. They run a support group on Revel for women in menopause who want to talk about menopausal issues. Anne and Monica are the founders. I think they're very, very smart. We have a Revel code 25. The code is Revel, REVEL 25. You can use that at checkout for $25 off your first order. And stay tuned. We do a alloy episode every month on our podcast with a different expert. I think last month we were talking about sexual health. They have a really great advisory team of people. I've been impressed with each and every one of them. I'm very excited to see them grow. The website is www.myalloy.com/solutions. And I think that's it. Well, where are you? Are you in your home? What's that pretty wall?
I'm in Martha's Vineyard.
Oh, lucky you. Nice.
Yes, but I'm on my way to Atlanta on Friday.
Okay. And do you live in Atlanta? No, you live in DC.
No, I live in DC, but I'm going to Atlanta for the National Medical Association conference there. So I will be in Atlanta.
Well, it has been great meeting you, and then we'll cut off the recording. But I did want to tell you, I had dinner with Malia in LA a few weeks ago because she's very good friends with my daughter,